Good afternoon. I'm Stephen Bailey, Editor-in-Chief of Catheterization and Cardiovascular Interventions. I'm joined today by Dr. Mohammed Khan.
Hello.
Who joins us from the Veterans Administration Hospital in Tucson. He's a hospitalist, and we wanted to have a conversation with him about a manuscript that's been recognized as an editor's choice in catheterization and cardiovascular intervention. Your colleagues and you discussed the effects of percutaneous revascularization of chronic total occlusions and its impact on clinical outcomes. This meta-analysis focused on successful versus failed PCI for chronic total occlusions, and I think has a lot of interesting aspects, but could I ask you to summarize those for us?
Absolutely. So, as you know, Dr. Bailey, that CTO intervention is a controversial topic, and we are not yet clear that opening a CTO will provide long-term benefits. So, when you look at the data, all the data is observational data, and there are key limitations in that sense that different authors use different definitions of CTO. So conventionally, occlusion which is present for more than 3 months is regarded as CTO, but some authors used occlusion of less than 3 months as CTO as well. And the other key limitation was that while comparing the long-term outcomes between successful CTO intervention and a failed intervention, the short-term complications of the failed intervention were not taken into account.
I think those are two important distinctions. Obviously, when to do CTO, how to do them has varied a lot over time and our techniques for doing it, but you're absolutely right. Making sure that we know what happens during that procedure and in the hospital and looking at its impact long-term is important. So tell me a little bit about what you learned in that meta-analysis.
So basically, we found 23 observational studies which compared successful versus failed intervention. There was not a comparison between percutaneous coronary revascularization and optimized medical treatment for the management of CTO. And those observational studies, they included about 13,000 patients. They were followed up for a period of about 4 years. And at the end of 4 years, when we compared the long-term clinical outcomes, it appeared that successful CTO intervention reduced the all-cause mortality by 50%. It reduced the risk of MACE by 30%, and it reduced the risk of subsequent bypass surgery for 75%. But there was no difference in terms of risk of myocardial infarction. And target vessel revascularization was actually 2 times more common in successful intervention group as compared to failed intervention.
Okay. And is that because they were revascularized and therefore had an opportunity for restenosis, or was this new lesions in the vessels?
They were the same lesions, and as you mentioned that they were revascularized, there was a stent there, and that's why if something happened, they went for a second target vessel revascularization through PCI. But in case of failed intervention, if the patients continue to have symptoms, I mean, it's understandable they are more likely to go for bypass surgery rather than another attempt.
Now, one of the features that always has been a criticism of many of these studies has been the fact that most of us know that if they're calcified or have certain characteristics with regards to the angiogram, a stump, a side branch, etc., that can influence whether or not folks even decide to try. Any insight into that, or probably, were you able to adjust for that?
So that's a very good point, and actually that was one of the key limitations of this meta-analysis, that the studies, the individual studies, they did not compare the calcification, the length of the lesion, and other component of JCTO score between successful and failed intervention. So it is possible that some of these results are because unfavorable clinical profile in the failed intervention group. But, in this analysis, we don't have, because we do not have access to individual data, so we couldn't adjust for that.
So, absent patient level information, it's really hard to come up with that.
Yeah, that's the individual kind of
So I think
data.
it's reassuring for us to know in our practice that approaching a CTO that we think could be opened, and if we do open it, carries improvements for our patients, not just short-term, but also long-term.
Yeah.
How do you see this study helping in terms of developing the next study, or where do you see it going?
So basically, this is not a comparison between a PCI and optimized medical treatment for the management of CTO. So that's the big next question. This is all the comparison between successful and failed intervention. And obviously, it has different limitation. It has a component of selection bias where patients with favorable angiographic feature are more likely to undergo a PCI versus unfavorable, which are who are more likely to undergo bypass surgery. But I think these limitations will be addressed by the randomized control trials, and we have currently 2 trials going on, and we see what we find with those randomized trials.
Well, thank you. I think that, again, this large meta-analysis does add to what we know. I believe it's going to contribute to our everyday practice. I think it'll help in these trial designs, and we look forward to the outcomes of these larger randomized trials as well. Thank you so much for spending a little time visiting with us.
Thank you very much.